Welcome back, clinical problem solvers. We're having another Rafael Medina subspecialty series, and today we are having none other than Dr. Gurleen Kaur, who is going to be discussing the case when Namita Ravi is going to be presenting the case. And both of them are from Brigham and Women's Hospital in Boston. And Namita is doing her PGY3, and Gurleen is a second-year cardiology fellow. And I'm just going to pass the mic to Gurleen to introduce herself and then pass it on to Namita to say hi. Before that, I do thank Julia Z to help us with teaching points and Anmolpreet with describing.
Hi everyone, I'm Gurleen. So great to see everyone. It's been a really long time since I've been on VMR, but I remember presenting the first case for the cardiology VMR a couple years ago when the series started. So it's really great to be on the other side and discuss. I'm a second-year cardiology fellow at Brigham, interested in critical care cardiology, and will be actually taking a year in between cardiology fellowship to go back and do internal medicine chief year, since in our program you do it after a couple years of fellowship, but really excited to be here and learn with you all.
Namita, did you want to introduce yourself?
Hey everyone, it's nice to be here. My name is Namita. I'm a third-year internal medicine resident, also at Brigham and Women's Hospital, and also interested in cardiology. Very excited to be here. Gurleen was actually one of my seniors and I was an intern, so it's very nice to now be here with her in this position as a discussant.
Yeah, I think she's one of the best people I've met, and I get to meet her when she was doing an amazing webinar on social media for women and how to use it responsibly. So I'm just so glad you get to spend a lot of time with her. Julia and Anmol, did you guys want to say hi?
Hi everyone, I'm Julia. I'm a recent medical graduate here from Brazil and very excited for this cardiology case.
Hello everyone, my name is Anmolpreet and I'm an international graduate from Punjab, India. I'm very excited for today's cardiology case, looking forward to it.
Great. And so it's going to be a women power today behind the subspecialty series. And I do like to start off my sessions with an icebreaker. And today we're going to go with what's the favorite thing you did during the summer? Gurleen, did you want to say what's something which you did fun?
Yeah, my parents recently moved to Connecticut from New Jersey, so we were exploring more in Connecticut, so spending some more time outdoors in the summer and some of the state parks and the beach. So that was nice. And Connecticut is closer to Boston, so it'll be nice to go back home often as well.
Wow. Namita, did you do anything exciting over the summer?
Not exactly the summer, but my most recent vacation, I was able to do a trip to Italy, which is actually my first time ever going. So that was very fun. Very good food and views.
Which part of Italy did you go to?
So we did Rome and then we took the train down to like southern Italy, like Amalfi Coast. Very pretty.
Wow. It's definitely in my bucket list to visit.
Very nice.
Yeah. The fun thing which I did was to be in Kashmir when Operation Sindoor happened and being stuck over there. But I was in the saffron fields, which was fun. Yeah, that's the fun thing which I did this summer. So we're going to kickstart the session, and whenever you're ready, Anmol, did you want to share the screen, or Julia, were you going to share the screen? I forget.
I will.
Namita, whenever you're ready, you can start off with the first aliquot.
I think you're muted.
Yeah.
Thanks, Gurleen. I'll start off with the first aliquot, which is just the presenting complaint and the HPI. I'll give the brief HPI, then Gurleen, you can ask if you'd like any further details. So this is a 29-year-old male who's coming in presenting complaint is 5 days of fatigue. So for a brief history, he's been feeling poorly for 5 days, fatigued, low appetite, nausea, vomiting, malaise, and feeling a little bit faint. He initially went to his school health services and they diagnosed him with a presumed URI and they sent him home with just supportive care. he now comes to the ED feeling worse, saying that he feels much more tired, fatigued, malaise, and overall just not doing well. I'll pass it to you, Gurleen.
Great. So I think when I think about fatigue, you have to think about not just cardiology, but put on your internal medicine hat and think about kind of what's going on in which organ system and keeping your differential pretty broad. I think there isn't much to kind of hinge on right now in terms of the information we have. So when I'm thinking about fatigue, I think the 5 days is helpful in terms of it seems like it's a pretty recent onset process. He isn't telling us anything that's been going on that's more subacute or chronic that would make me think that there's more of a kind of a longer standing illness, but that might be information that we need to ask the patient to really see, did it actually start 5 days ago or did it start a lot before that? And this is just the fatigue has been the more closer symptom. And then the low appetite, nausea, vomiting. I think right now our differential is broad. Is there something GI happening? Not absorbing any sort of viral illness, any sort of infectious process that's acute, that's causing a disbalance of things leading to fatigue. Is this a pulmonary process with the fatigue? What does fatigue mean to that patient? Is it shortness of breath? Is it fatigued in that they can't walk? Like, is this a musculoskeletal fatigue? And then obviously the heart, which I like to think about a lot. When I think about fatigue in terms of the cardiac system, I think about, is it some sort of like chronic heart failure process where they're feeling short of breath and not really having the energy because of low cardiac output to do their day-to-day things. So I think based on what we have right now, those are kind of like the big buckets and organ systems that I'm thinking about. And I'd like to know in kind of the things I would ask for would be any like fever, chills, any sort of systemic signs, any lower extremity edema, orthopnea, PND, or chest pain to suggest involvement of the cardiac system, and then kind of any recent travels, like who is this patient, what are they predisposed to. Usually when you think about a 29-year-old, you're thinking about more common things being common. Is this just a URI or a viral gastroenteritis? But knowing more about what this patient's past medical history is going to help frame how concerned we are about the fatigue. And then I think one last thing is a lot of times in cardiology, when heart failure presents or when other things present, especially in young patients, people just kind of ascribe it to a URI or something, and they might have gotten treated for asthma or for something else in the outpatient or urgent care setting. So you really have to ask yourself, did they get better with those treatments, or is this something broader going on that we're missing?
Awesome. Okay, perfect. So I can flush out on that topic. So to qualify his fatigue, it's primarily fatigue on exertion. So kind of any low-level activity makes him feel extremely tired. He denies any fevers. He did initially feel a little bit feverish, but has not taken a temperature at home. He has for other like review systems, he has a diffuse headache, but to answer your questions, he's not noticing any orthopnea, shortness of breath, or chest pain. He's not having any cough or rhinorrhea or kind of URI symptoms. Regarding the GI symptoms, no diarrhea. It doesn't think it's related to food triggers, but he does feel kind of persistent nausea throughout the day. And then he also mentions that he feels that he's just getting like exhausted with any kind of activity. Regarding like who he is as a person, so he's a graduate student at a university in Boston. He doesn't have really any notable travel that he can tell us. His only past medical history is depression and ADHD, for which he takes 2 medications, sertraline and Adderall, but aside from that, he's not taking any chronic medications. And he pretty much until this point has been quite healthy and doesn't have any known medical conditions to date.
Gurleen, when you are talking about, or the patient tells you there's a fatigue for just 5 days, do you prioritize something more an acute process happening versus a congenital heart disease, for instance? Or is there any triaging which you're doing when you're hearing it's just a short-term complaint versus like it's been there forever, it's just become worse now?
Yeah, I think definitely. I think if this was someone who's suffered a lot of past medical history by the age of 29, if they've had other bouts of similar episodes or any other symptoms that made them think that they might have something chronic going on. It's very different than right now. It seems like he's been completely fine until 5 days ago when he started having worse fatigue on exertion. So really, this makes me think about what is an acute process that's involving the pulmonary or the cardiac system, where he's having dyspnea with exertion. I think he hasn't said dyspnea, but just being fatigued on exertion makes me think that there's something going on in the cardiopulmonary system, where when he's requiring an increased metabolic demand and increase with activity or exertion, he's having some sort of fatigue from that perspective. And so I think I'm narrowing in from the first aliquot to now thinking about cardiac etiologies, thinking about pulmonary etiologies. I think anemia is still on our differential. People can feel really short of breath when they're more anemic. And so thinking about hematologic things that might be occurring in the background. It seems like he hasn't had any kind of like prodromal viral symptoms prior to this fatigue on exertion, because that would be something to think about. Did he have some sort of illness and now he's having the sequelae of that illness that's still lingering and causing him to be short of breath? I think in someone who's young and 29, really thinking about genetic causes and family history is also really important. So doing like a 3-generational family history, asking about any history of sudden cardiac death, any history of arrhythmias, any history of someone drowning or passing out without knowing, any personal history of syncope. Those would be other things to think about. I think the fact that he hasn't had any recent travel makes me think this is less likely some sort of atypical infectious process that's more prevalent in other countries or somewhere where he could have traveled. So I think that's where kind of I am right now. And I think the physical exam is going to be really important in honing in on an organ system.
Amazing. Aliquot number 2 is the physical exam, so that's perfect. So this physical exam was done at an outside hospital before he actually came under our care. So some things that you may want, I may not have, but I'll give you what we have so far for the physical exam. So he comes in with for vital signs, he's afebrile, his heart rate is elevated, he's tachycardic with a rate of 113 beats per minute. His blood pressure is 104/60 on arrival. He doesn't really check his blood pressure, and we don't really know a baseline. His respiratory rate is 14, and he's satting 94% on room air. For his general appearance, he appears diaphoretic and fatigued, but he is awake and oriented and speaking coherently. For his head, neck, and throat, he has reactive pupils, normal conjunctiva. They comment that his mucous membranes look a little bit dry, but otherwise his nares are clear. And importantly, he does not have like meningeal signs, so no neck pain or neck stiffness. For the cardiovascular exam, they comment on a regular rate and rhythm. There's no audible murmurs, but they unfortunately don't comment on a JBP. And then for his pulmonary exam, they do note mild inspiratory crackles, but otherwise normal respiratory effort on room air. His GI exam is pretty unremarkable. His MSK exam is unremarkable. And then for his skin exam, they do note that he feels warm. And his neurological exam, besides the fatigue, is otherwise totally normal.
Gurleen, we do have a question in the chat about how are you tying up the nausea and vomiting history with the fatigue and the cardiopulmonary system for this patient?
Yeah, definitely. I think a lot of times nausea, vomiting can be a cardiac symptom, like especially in someone who might have a low output state, even if their heart pump is not working well. Sometimes one of the manifestations of people in bad heart failure or shock from a cardiac perspective can sometimes just manifest as kind of GI symptoms because they're not getting good blood output to their organs. I think other things like even not in a 29-year-old who doesn't have those risk factors, but in another patient, nausea can be an anginal equivalent or kind of be a symptom of some sort of coronary process going on. I think I'm thinking less of a coronary process right now in a 29-year-old who doesn't have any family history, is relatively healthy, but it's not something that you can exclude. I think young people can also have really bad disease and other sorts of kind of undiagnosed conditions. So I think that's still important to think about. And then sometimes endocrinologic things are things that can tie nausea and vomiting and kind of these kind of systemic like symptoms with fatigue and cardiac symptoms, because any sort of effect on the thyroid or other adrenergic hormones can lead to kind of non-specific symptoms as well as affect the cardiac system. I think the other thing that would be helpful to know, I don't know if you already mentioned this, Namita, and I missed it, but any sort of substance use history would be helpful to know about, because things like toxins can really affect the heart and the heart muscle, like things like cocaine, methamphetamines, and can cause kind of non-specific symptoms like the diffuse headache and other things that the patient was presenting with. I think the physical exam is a little helpful, but not really helping me kind of hone in on a specific process. It seems like we don't see evidence of frank volume overload whenever we're thinking about the cardiac exam, thinking about from a volume perspective, is this patient having any sort of elevated JVP or lower extremity edema to suggest that this is not just 5 days of symptoms, but something going on for a little bit longer, and maybe he only realized in the last couple of days. But it doesn't seem like that from the information that we have. And so it seems like he is hypertensive for a healthy 29-year-old. His blood pressure shouldn't be in the 140s. I think it was in the 140s, right?
Oh, it's 104.
Oh, 104. Okay, sorry.
Yeah.
Never mind about that. I read the numbers wrong. He has some sort of inspiratory crackles, which could again mean some sort of heart failure or something else in the pulmonary process. I think what's really going to be helpful is seeing if there's something in the labs or imaging or the EKG that really lets us hone in on something in particular. But I think right now I'm still thinking about those big buckets that I mentioned.
Perfect. And I can give that labs in the third aliquot, or are there any particular labs that you would send off right away as first pass workup?
Yeah, I think it would be really helpful to see like if he has some sort of anemia or some sort of process. I think a thyroid level, um, basic labs to see are there electrolyte derangements that could explain his fatigue. Um, Seeing an EKG, are there things that make us concerned in a 29-year-old of something going on that is more than just kind of the non-specific symptoms that he has. I think all of those would be helpful.
Awesome. Okay, so for the third aliquot, I'll give you the first set of labs that was gotten in the ED on admission. So he has a BMP that's notable for a creatinine that's at 1.4. He has no priors, but presumably it was previously normal. And his bicarb is down to 19. The rest of his BMP is within normal limits. His other electrolytes, his mag, his phos, his calcium are all within normal limits. For his CBC, that's totally normal. So he's not anemic. He has a hemoglobin of 15. He does not have a leukocytosis and his platelets are totally normal. They did get a TSH that was normal. And then for other labs, they got LFTs that were elevated, AST of 408, ALT of 64, and ALK phos of 94. His T-billy is 0.7 and his D-billy is 0.5. His lipase is within normal limits. I think, Gurleen, you mentioned they did get a tox screen. It was positive for amphetamines, they presume because of the Adderall, and then it was also positive for THC. His UA showed trace ketones, but was otherwise not infectious. His respiratory viral panel was negative. And then for cardiac labs, his troponin was elevated to 73. His CK was elevated to 86. And then his lactate was elevated to 7.
I think
those are all they got on admission. Yeah.
The thing that really takes my, it was really surprised by was a lactate of 7. I think whenever you're thinking about all the other labs, I think are helpful, but a lactate of 7 makes me really concerned about what is going on systemically. Is this patient in a hypoperfused state? Especially when we think about the cardiovascular system, you can be in a low output state in like kind of a normotensive cardiogenic shock picture, even with a normal reassuring blood pressure of 104/60. So the fact that the lactate is elevated, I think I'm thinking about, is there a process of low output? Is there some sort of systemic infection that we're missing? It doesn't seem like he had any elevation in his white count or anything else in terms of the viral panel or something that could explain that high lactate. And then with his nausea and vomiting and that lactate elevation, also thinking about a GI process, especially with the elevated LFTs. Is there something in his abdomen that's causing an elevation of lactate and organ malperfusion in the gut, as well as LFT abnormalities? When I think about the LFT abnormalities, it's notably the AST is a lot higher than the ALT. So you're thinking about things besides the liver. So cardiac processes, you can also get AST elevation, or also if you're in a hypoperfused state and you're getting kind of congestion from that, you can have an elevation. In terms of the toxins, I think it seems like the amphetamines are from the Adderall, but I think that's something that I'm still thinking about if he's used any exogenous methamphetamines that can definitely lead to fatigue and some kind of subacute symptoms. I think the next thing I would do is like put a probe on the patient to see what does their cardiac output, cardiac function look like, what is their biventricular function with an elevated lactate. I think something that we think a lot about is how warm or cold are the extremities, but just out of experience, sometimes people can be warm when they're young and look fine, but be a state that their heart is not doing that well. And so I don't think I'm reassured by the warm extremities. That could mean there still is something that could be wrong with the heart. There still could be a kind of a multifactorial process with two sort of things going on superimposed that could lead to warm extremities, but still something that's not working well from the heart perspective. So knowing kind of what the biventricular function looks like, what do the patient's valves looks like, it seems like there's no like white count or other things that are making me think about some sort of systemic process like endocarditis, but I think that's something that's still on the differential with non-specific symptoms and some of the kind of end organ manifestations that we're seeing, right? His kidneys are being affected, his liver is being affected, and so you're really seeing this end organ malperfusion. The other thing that I wanted to mention was I think the troponin you said was 73. So when we think about troponin elevation, I think what it is it's just a marker of myocardial injury. And so we have to decide where is that myocardial injury coming from. And in someone who has risk factors for coronary disease, someone who's older, you should always think about, is there some sort of coronary process that you're missing? But this doesn't sound like, in terms of who the patient is, the time course of symptoms, that there's an acute plaque rupture or a type 1 event. So then the troponin can be elevated because of demand from some other process that's leading to a supply demand mismatch, or some sort of myocardial process that's leading to an increase in myocardial injury, whether that's like myocarditis or some sort of other systemic process.
Great. When you see a drop of 76 and CK of 86, like, do you feel like it? I mean, they are elevated, but then do you give some kind of importance as to what exactly is happening with the things, or?
Yeah, I think CK is non-specific, right? It can be a little bit of muscle, it can be a little bit of heart. CKMB is useful if you think someone to really localize in terms of myocardial process, but I'm not making I think it's helpful to see that there's like multiple things happening in terms of organ systems, but it's not really helping me differentiate right now at this point. But I think we need to like really see what the heart is doing in terms of its biventricular function, because I think everything is pointing towards the heart is not perfusing the kidneys, the liver, the extremities, the organs.
Okay, thank you.
Yeah, so unfortunately, they don't get a focus on this patient in the ED. He does get an echo later on in the course, but we don't have one at this moment. For the next aliquot, I can go through kind of the basic imaging they got when he came to the ED. So they did get CT scans on him. CT head and CT abdomen were read as totally within normal limits, and then they got a CT chest that showed dense consolidations in the bilateral upper and lower lobes, likely representing atelectasis. And then they noted more centrally distributed ground glass in the remaining lung segments made to represent mild pulmonary edema. And then they also noted small bilateral pleural effusion and mild diffuse anasarca may represent third spacing. At this point, when he's in the ED, he starts to feel like more nauseous, starts vomiting, and while ambulating to the bathroom, does get lightheaded and fall. So at this point, they give him 2 liters of normal saline and they get an EKG, which I can show if I can share my screen. I don't know if I can share my screen.
Give me one.
Give me a second. Oh, I don't know if I can share it, but
Yeah, I'm just going to make you co-host, so you
okay.
should.
Oh, there, perfect. Thank you. Okay, so then while he's conscious, they get this EKG. So obviously a frightening EKG. So Gurleen, when you like see things like this, like wide complex tachycardia in somebody who's like young and otherwise healthy, like what is your framework and what do you do and how do you approach it?
Yeah, definitely a concerning EKG in a 9-year-old. Very wide, complex. I think the first thing that you always want to think about in a new wide complex almost kind of is electrolytes. Like, are they hyperkalemic? What is their potassium? If you didn't know anything about this patient, that would be the first question that I'm thinking about as well. It seems like the rate is not super fast, even though it is wide complex. So some sort of kind of slower monomorphic morphology. Though I think in this patient with systemic signs of hypoperfusion, we're concerned that this is ventricular tachycardia. I don't know if you mentioned what the potassium and other electrolytes were, but that's something that I would want to make sure are okay. And so the first thing is like when you see this, like, does the patient have a pulse, right? Are they stable? Are we going down the ACLS route, or are we going down treating this medically and figuring out why someone is in a hyperperfused state, as well as having evidence of ventricular arrhythmias? When I think about like troponin elevation, hyperperfused state, and ventricular arrhythmias, one thing that we always need to think about is myocarditis, because you have to have a high clinical suspicion for this entity, and especially if you're thinking about ways to change management. If you think this is something fulminant like giant cell myocarditis, or something where you want to treat with steroids, that should be something going on kind of like the back of your mind. Like, how are you going to get this patient out of this really sick state that they're in right now? And a lot of times these 29-year-olds can look okay, even though they're like really sick with those labs, because nothing in the general appearance of the physical exam did we hear that this patient was an extremis. But looking at the labs and EKG, I'm a lot more concerned.
Perfect. So to answer those points, so going back to his BMP, his K, his MAG, his calcium were all completely normal. So it didn't seem to be an acute electrolyte imbalance that was driving this. At this point, when they initially got this EKG, he did have a pulse. And then later on in the ED course, as I mentioned, when he had the fall from the bathroom, then he slowly started to become, his pulse began to get weaker. And ultimately, like Gurleen was saying, ended up going down the ACLS route. So that is how the management took place in the ED. So obviously all the diagnostics you wanted earlier, like the echo, were delayed for that reason. But the patient was ultimately stabilized post like resuscitation. And at that point, they were able to get an echo that I can go into as the next aliquot. So the echo was read as an LV with the significantly reduced ejection fraction, as LVEF was down to 10%. And there was a note of diffuse hypokinesis with regional variation, least prominent in the mid infralateral segments, but pretty prominent everywhere else. His RV also had significantly reduced RV systolic function. Both the atria were normal in size. And all of his valvular valves appeared intact and fully functional, and there was no large pericardial effusion. And I'll stop there for Gurleen to talk about the diagnosis and things.
Yeah, so this is a really sick 29-year-old with a really reduced ejection fraction. It seems like you said the right was reduced as well, right? So it seems like this is a biventricular reduced systolic function. I think things that are also going to be helpful to me when I'm thinking about the echo is like, how dilated is the left ventricle? Is this some sort of dilated cardiomyopathy versus is this, it would be weird to have an EF of 10% where the LV hasn't dilated, but that changes your differential, right? Or is this someone with really thick walls for some reason and we didn't know that they have hypertrophied heart with a really low ejection fraction? And so that really changes your differential. Are the walls thick or is the chamber dilated? Because you're going down the route of hypertrophic causes versus dilated cardiomyopathy. I think with the information we have so far, I think we've kind of confirmed a low output state was all in the setting of a cardiac process, leading to kind of those non-specific systemic manifestations and low end organ perfusion. So the next question is, why is the biventricular function low? And is there something that we can do acutely to reverse it or not? It seems like it hasn't been going on for that long. So I think I'm still really concerned about myocarditis from some sort of viral cause that we haven't identified. Myocarditis can cause for ejection fraction to go down, but it can also present in someone with a normal EF. Usually with myocarditis, I think of the troponin elevation as being a lot higher. The 73 isn't kind of typical of really rip-roaring myocarditis processes, but that's not to say that it can't happen. I think the methamphetamines is something I'm still thinking about. It can cause dilated cardiomyopathy, and I'm not sure if the Utox was just because of the Adderall or if there's something else that we don't know yet about the patient. When I think about methamphetamines, I also think about they can lead to pulmonary hypertension, but I think that's more in the subacute chronic phase. But knowing in this echo would be helpful to see what does the RVSP look like. It seems like there's no valvular things, but just with the dilatation of the LV and the RV, I wouldn't be surprised if there's some degree of mitral regurgitation and some sort of tricuspid regurgitation just because of dilatation of the chambers. And then when we think about kind of the big buckets of, is this like toxin-induced cardiomyopathy, or is this some sort of inflammation, myocarditis? I think this is really relevant to this patient, but like taking a step back, right now we basically have reduced LV systolic dysfunction. So your big buckets, if this was an older patient, you would still always think about ischemia and ruling out ischemic heart disease. And then the other big buckets that you're thinking about are infectious, inflammatory, endocrine, toxins. And in this patient, I think the clues we have so far, the only places where we're seeing some sort of connection is possible toxin and possible inflammation, infection that we haven't picked up. And then, as I said before, the reason where myocarditis is helpful is if it's a very fulminant process, which it seems like it is here, you're thinking about, should you give really high dose steroids to treat things like giant cell compared to other less fulminant types of myocarditis, like lymphocytic myocarditis, where you don't necessarily see any benefit from things like steroids.
So what are you thinking about, like, like to see what the cause is or how to manage the patient, or is it like both are on the same level of importance at this point?
Yeah, and I think that's a really important question because right now it seems like the patient is really sick, and it's really about stabilizing the patient, since it seems like he arrested, so it's like post-arrest care, seeing what his mental status is like. I don't know how long he required CPR and ACLS, but thinking about kind of managing all of the critical care needs for that patient is going to be important. And in the background, I think the one question that I have is to give steroids or not, because if this is some process where we're thinking about giant cell or some sort of other fulminant myocarditis, the only thing you can do in the acute management besides stabilizing the cardiac system, the pulmonary system, post-arrest care is really giving steroids to reverse whatever inflammation or anything is going on. So I think that would be the kind of the thing I would think about really strongly, because in all of these diagnoses, in the end, you need tissue to diagnose, but this patient is too sick to go anywhere near a cardiac MRI or to go anywhere near an myocardial biopsy. But thinking about steroids is going to be important.
Perfect. So exactly as Gurleen said, so the next stage in the case was when he was found to have VT and ultimately lost his pulse. So at that time, the primary focus was stabilization and pretty much like ACLS care. So ultimately, he had refractory VT despite multiple antiarrhythmic infusions, and it ultimately had to be flown over to our hospital to be placed on mechanoCirculatory support. And that's ultimately how they were able to stabilize him, was on ECMO. At that point, they were able to finally get like a proper TTE. So I can try to show the images, and Gurleen, maybe you can comment on them. This is the TTE after, and you can see the unloading impella in place, but if you can ignore that, you can look at his walls and see if, I know you're wondering if he was dilated or hypertrophic, so maybe you can tell it's not the greatest angles, but.
Yeah, I think it's hard for me to see kind of without like putting my lines and seeing how dilated things
Yeah.
look, but it still seems like the LV is dilated and the ventricle is a little thick as well from what I can tell from this view, but you really can't see the posterior wall that much. But just looking at the septum, it looks like it's bigger than I would thought of a 29-year-old with past medical history of kind of no other process that we know about. So I'm thinking about that, like, are there other hypertrophic causes that we're missing, like some sort of infiltrative cardiomyopathies where you can have ventricular arrhythmias as well as kind of really fast decompensation because of biventricular involvement. I think the question, it seems like right now this patient was in VT storm that required mechanical circulatory support to really stabilize. And I think the next question is, what exit strategy does this patient have? Because it seems like with the degree of myocardial dysfunction, they're not really going to be able to recover. So is this mechanical circulatory support a bridge to recovery if we identify a reversible process, or is this a mechanical circulatory support as a bridge to a destination therapy, which would be transplant for someone that's sick on ECMO with an Impella for venting? I think when we think about, as I had mentioned before, dilated and hypertrophic cardiomyopathies, for dilated, I was really thinking about methamphetamines, thinking about giant cell myocarditis. For hypertrophic, any sort of like thickened ventricle, you're thinking about, does this patient have longstanding hypertension or hypertensive heart disease? In a 29-year-old, less so, right? If this was an older patient with a history of hypertension, you could think about whether their hypertension has progressed so much that they've developed hypertensive heart disease. And so in a younger patient, and then an older patient, you would also be thinking about things like amyloid, or sort of other kind of older stage cardiomyopathies. In a younger patient, thinking about like things like glycogen storage diseases, Fabry's disease, things that can cause accumulation of something extracellular and deposits. But I think the echo is really helpful here because I think it puts into context kind of what the ventricle is doing, and it seems to be a component of dilated and hypertrophy from what I could tell from that one image. But it'd be helpful to see other images, because whenever you're making assessment in echo, it's kind of putting the different planes together to see what the full kind of picture is.
Perfect. Awesome. Okay, so for managing this patient, so like you said, they tried to kind of treat any kind of reversible possible causes of myocarditis. So he was given high dose steroids. He was given pulse dose of solumedrol to try and treat possible like giant cell myocarditis. He was also given anti-thymocyte globulin in case it was like a T cell mediated process. So we got two kind of anti-immune therapies to target from that front. And then once he was stabilized on echo, they actually, on ECMO, they were able to get tissue biopsy to kind of confirm what was actually going on with this person. So the biopsy was read as active myocarditis, lymphocytic, and diffuse with severe edema and multifocal injury and infarction. There were actually no giant cells and no vasculitis. And the inflammatory mixture was composed mainly of like CD3 positive T cells and macrophages. There was no evidence of granulomatous inflammation, no evidence of recent infarction, no amyloid or iron deposition in the heart.
Yeah, that's super interesting. And I think that's what we were mentioning earlier is really steroids is the one thing that you can change management in for myocarditis. So it makes sense in someone who is so sick where you don't know what type of myocarditis they have to give really high dose immunosuppression. And definitely like steroids and ATG is what we think about. The other, just to mention, this is not relevant for this patient, but the patients that I've seen that have been like super sick with fulminant myocarditis where we've given ATGs, also ICI myocarditis. So if this was a cancer patient who's at any sort of immune checkpoint exposure, that's something to always kind of think about as well. I think it's interesting that the biopsy shows lymphocytic. Usually I don't think about lymphocytic as causing the same degree of kind of fulminant picture as I think about for giant cell. That being said, biopsies, obviously they're the gold standard for diagnosis, but when you're doing a biopsy, you're going in and kind of only sampling one portion of the RV. So if you did have a patchy process, which it seems like we're still kind of, even though the diagnosis we're thinking about is lymphocytic myocarditis, things like sarcoid can also present with granulomas and kind of inflammation, and you can miss that on a biopsy, because if you go in and biopsy an area where you don't have active granulomas, it's possible that you're not seeing it. So that's, I think, something to think about as well. But with lymphocytic, you kind of think about any sort of viral or other mediators that might have led to nonspecific inflammation in the myocardium.
Gurleen, just from his presentation and what's happening with him, would you call this as a fulminant myocarditis?
Yeah, definitely. I think fulminant myocarditis, I'm thinking about if there's really bad cardiogenic shock plus arrhythmias. And if someone is on mechanical circulatory support, definitely fulminant. But even if he was sick enough but not requiring mechanical support, he would still kind of classify as fulminant myocarditis because of the effect on the conduction system, the effect on the ventricular process. And when you think about fulminant myocarditis, they can lead to both ventricular arrhythmias, but also kind of higher grade AV block. So complete heart block, conduction system abnormalities, those are things to kind of keep in mind.
Okay, thank you.
And Gurleen, one thing I was wondering when he like came in was kind of what the acuity you think of the process was. Like I know he was feeling not so great for 5 days, was typically like the viral insult, and then a few days later you develop this acute process, or do you think the like low EF had been smoldering for many days and he finally came in when it tipped him over? Like could they have caught it days ago, or how do you think of the timeline typically?
Yeah, usually myocarditis is an acute process, right? So like less than 30 days is what we think about for acuity for myocarditis. That being said, I don't think his symptoms were just like 5 days, right? Like his EF
Yeah.
5 days ago
Yeah.
was probably not completely normal. And I think that's what happens in a lot of these young patients is they have so much ability to compensate because he's otherwise healthy, doesn't have other comorbidities, that they feel fine until they don't. And that's when they really tip off that kind of that cliff. And when he presented, his lactate was 7, his creatinine, his LFTs. So there was some sort of like process going on for longer than he recognized, but still probably pretty acute for myocarditis. So not something that's been going on for a couple of months or something.
Great. So going back to your point about bridging, like what the bridge is for MCS to its like endpoint. So he unfortunately with steroids did not show recovery of his EF over like the next few days. It was like exactly as you said, they were worried that he would not be able to recover his EF. Thankfully, this case has a good outcome. He was able to be listed for transplant. He was able to get a heart transplant 12 days post his arrest. And I actually was taking care of him kind of later on in his like post-transplant course. So this went very well for him and he was able to get a heart and come off MCS.
That's great. That's good to hear when young patients that are so sick do well, because it can be really challenging to take care of these patients. And so how did your team kind of think about the lymphocytic like the lymphocytic results? Because I usually don't think about it as fulminant in terms of myocarditis, but was there any concern for some sort of more systemic process like sarcoid?
Yeah, I think even the attendings were confused when the biopsy results came back because I think people were expecting it to be like giant cell or something else. The point that you mentioned that maybe it was focal was brought up, but ultimately I think they weren't really thinking of sarcoid. I think they just ultimately decided this was just a really, really bad case of like lymphocytic myocarditis. But yeah, exactly the same confusion that you raised was like raised by the heart failure attending as well, because it's not typically how lymphocytic myocarditis presents, and they were anticipating something different.
And how would you differentiate an eosinophilic myocarditis from a lymphocytic myocarditis, and would it change your treatment post-transplant or?
Yeah, I think in the acute setting, when we think about myocarditis, I think the one kind of branch point, as I mentioned before, is usually think about giant cell as being super fulminant, so that you should give steroids. And for eosinophilic, you're looking at, is there any other sort of things in your peripheral blood in terms of elevated eosinophil count or other things or other toxins? But it wouldn't necessarily change management in thinking of, in this patient who's super sick, went into VT, needed mechanical circulatory support. Obviously the diagnosis is important, but to kind of make sure we're not missing some sort of reversible cause or some sort of genetic cause that has implications in other people. But in the end, this patient really needs a kind of a bridge to some sort of destination therapy. And that has to be hard if he doesn't have recovery. Some people with myocarditis, can recover. And that's why ECMO and other mechanical circulatory support are good options. Even if they're like an older patient who might not be a transplant candidate, you can put them on mechanical support if you think this myocarditis is going to recover just with steroids or some sort of short-term treatment.
Wow. And
Then
how
the
long,
other question, oh, go ahead.
how long do you think you can just keep them on mechanical support, waiting and hoping that they will recover? I mean, what's your cutoff before you make a decision whether this patient is not really going to recover with just the mechanical support and something more needs to be done?
Yeah, definitely. And I think when you think about how much support someone needs, like when this patient was crashing and not doing well, just supporting the left side isn't going to work. With something like a microaxial flow pump that's rotating in the left ventricle and taking blood and spitting it out in the aorta, this patient had a biventricular process. So you need some sort of mechanical circulatory support that's going to really support your left ventricle and your right ventricle. And in these situations, there's either kind of two options, and it depends on which institution and what expertise you have available at the institution. So ECMO is an option that's going to support both your left side and in your right side. But the problem becomes because in ECMO you have blood kind of coming retrograde into the LV. If your left ventricle is really weak, like his was, with an ejection fraction of 10%, you don't want to overload the LV with that retrograde flow. So usually leave in like a microaxial flow pump, like in this patient, which was the Impella device, to actually vent the left ventricle and allow it to kind of take blood from the ventricle and spit it out into your circulation. So the LV isn't having that extra afterload to deal with related to ECMO. Or if you don't, ECMO is one option, and that's usually the fastest option because you can put these really sick patients on it really fast. If you have more time and someone has biventricular failure, there's also certain places where you can do kind of a biventricular Impella, where you can put in an Impella or a microaxial flow pump in the left ventricle as well as one in the right ventricle. So it's unloading both of the ventricles that aren't working. But usually in myocarditis, if you're putting any sort of MCS, you should see some response in like several days to like a week or so. If you're not, then you're concerned that you need some sort of destination therapy. And then you're also monitoring, obviously doing serial echoes to see if they're having kind of function kind of come back, but also what are their inflammatory markers doing? What is their troponin doing? Are there other signs of recovery or effects of the steroids?
And then the other point of like kind of controversy or discussion that came up when treating this patient was the use of ATG, because I know for myocarditis, we often empirically give steroids if we're worried it's going to be bad, but ATG was not so commonly given. I think this patient came in obviously so sick, flighted in BT storm, that they gave him everything, but post-transplant course was very complicated due to multiple sternal wound infections because of how immunocompromised he was. So there was some back and forth about, when would you give ATG? When is it warranted? But ultimately it was decided that for this patient, because of how sick he was, it was the right thing to do to just kind of give everything. But
yeah, and it's often hard because like retrospectively now they had the sternal wounds, but
yeah,
if you hadn't given it and the patient hadn't done well, then you
yeah.
could retrospectively be kind of thinking the opposite of whether the amount of immunosuppression that you provided was not adequate to really dampen the inflammation.
Mhm.
And I think like the times that I've given ATG in the CCU has been mostly for like ICI myocarditis.
Okay.
Similarly, right, if you have some sort of fulminant
Yeah.
rampant process where someone's in cardiogenic shock with mechanical circulatory support, it's always a risk versus benefit. You're obviously going to increase the risk for infections, but it's tough. Like in this patient, it seems like he didn't even respond to that degree of
Yeah.
immunosuppression. So it was a really kind of rampant process.
Yeah. But he came back on the same service. I saw him again this year and he's doing much better now. So the case actually went very well for him.
I'm so glad to hear that, Namita. And is he still on the immunosuppressants, or is
Yeah,
he?
so he's now followed by the transplant team and maintained on immunosuppression and doing well with his transplant.
Okay. And someone in the chat had asked, recommended that we do an amphetamine metabolites. And did you guys get that as well to see if
That
it's?
was, yeah, that was actually never done. So I guess maybe they weren't thinking about that so much. I actually don't know much about amphetamine-induced myocarditis or whether that would have been more reversible in a different way, but I'm not sure. But that was actually never checked. So
And another question, or a differentials which was brought up was a Danon disease, and was that part of your differentials?
No, that was not mentioned. I'm not sure. That was not brought up.
Okay, and tuberculosis was another one which we have in the chat, and was there any consideration for that?
For what, sorry?
Tuberculosis?
Yeah, so the biopsy didn't show TB. Andy had no kind of travel or risk factors for TB, so TB was not that high on the differential, but the biopsy did check for it and didn't find TB.
Perfect. And amazing case. And what was your takeaway from the whole thing, apart from the fact that it just feels like very, very fulfilling to see a patient who presents to you with so much of acuity, and and then he does recover well and do good with all our efforts. Like, was your main learning from this?
I think really important learning for me, and that's been reinforced by seeing other patients who are also young, is how, like Gurleen was saying, how okay sometimes they can look until things get very bad. Like 3 of the sickest patients I ever took care of were in their 30s and were looking fine, then immediately were doing not fine and needed like aggressive intervention. So that was good learning for me, is like seeing how quickly someone can decompensate if they're healthy appearing but have like serious conditions going on. And then just kind of knowing the kind of workflow of managing myocarditis, like first stabilize and then try steroids if you think it's bad. And that was helpful for me to take away. And I think sometimes when people are this sick, like realizing that you just need to get them to like MCS faster rather than delaying. I think that was really important in his case. And for me, like good learning to say, like, they did not kind of waste any time with it. The second he came, it was almost immediately the shock team was activated. I think that really saved his life. So that was good learning for me.
Gurleen, did you have any takeaways from this, or 3 most important teaching points which you want us to remember?
Yeah, I think this was a great case. Thank you, Namita, for presenting it. I think, as Namita mentioned, really in young patients, they can be really sick without really looking that unwell. So really looking at if anything is wrong in the labs in a 29-year-old, you should be concerned, right? He should not have an elevated AST and an elevated creatinine. And really, when you're thinking about cardiogenic shock, you can have a normal blood pressure, but be in a low output state. So that's really important to remember. And that's where it's important to check your end organ perfusion markers, right? Here, the labs really helped you know that the patient wasn't perfusing his organs, even though his blood pressure was fine and even though he was quote unquote warm on exam. People can feel warm, but really like looking at the whole picture is really important for this case. And I think the other thing, like Namita mentioned, like taking care of this patient is not a one person job, right? This is a multidisciplinary shock team of knowing how fast you escalate someone to your devices, what's the right time, how do you think about the transition to transplant. And I think that's what makes cardiology so fun and exciting, is that we have ways to fix people and we have ways to really think about different processes in an interdisciplinary way, where you need the interventionalist to put in the device, you need the electrophysiologist to think about how to manage refractory VT storm, you have the heart failure doctors really thinking about where is this going to be a bridge to, and then the most important, you have the critical care cardiologist really thinking about how to tie together the different aspects. And so really the multidisciplinary care, as well as like steroids. I think the other teaching point is really thinking about steroids when you have fulminant myocarditis with ventricular arrhythmias plus a poor biventricular function. And you just have to have your clinical suspicion for myocarditis always, because it's not something that's just kind of presents with the same illness script every single time.
So if we see an ST elevation and trop elevated, we do not activate the code ACS, right? Thanks once again for everyone for joining, and thank you so much, Gurleen and Namita, for presenting and discussing the case. And I hope you guys have a wonderful rest of the evening and great rest of the month as well. Thank you.
Thank you.